Hello, everyone, and welcome to the Guide to Psych Patients in the Emergency Room. Here are a few of my tips and tricks on dealing with your psych patients in the emergency department. So, shocker, and a big disclaimer here, I'm not a psychiatrist. I trained as an emergency medicine doctor, and this presentation reflects a lot of my opinions as well as how I practice, which means that this is not medical advice. It's intended for my professional medical students only, and mostly for education and entertainment purposes, which means that if you're a patient and you're listening to this, this is not applicable to you. I can also tell you that all of these facts need to be checked for you and your hospital policies, because a lot of these things change by state and they also change by county. So it's important that you know that just because I practice this way does not mean that this is appropriate for your practice. Now, that being said, I want to also make sure that I address this big fact, and that is 48% of missed diagnoses in the emergency department are in this patient population, the psychiatric or the intoxicated patients. And it's really important that before we get into managing these patients, you understand that psych patients or intoxicated patients can be sick too, with regular medical diagnoses, and they're missed a lot, because a lot of what's happening in their medical care ends up getting blamed on them being a psychiatric patient or them being intoxicated. So it's important to always have in the back of your head the idea that they can have a medical problem as well. Look for clues that would give you information on the fact that they could have a head bleed, or they could have a pneumonia, or they could have something else going on besides them being a psychiatric or intoxicated patient. Please always keep this in mind. Okay, here's a quick couple of statistics. A lot of these are statistics from 2016 or previously, and a lot of these statistics change year by year. What I want you to get out of this is that the most frequently diagnosed patients for this area is going to be down here. So it's either going to be acute substance intoxication that includes alcohol or any of the drugs. And then the second most frequent patient that we see in this category is going to be the suicidal patients. You already know that probably without me telling you that. And this patient population has the highest rate of return of any patient population. They come back over and over and over again. Okay, the average length of stay for these patients is typically really high. We have a really big problem with holding on to these patients for very long periods of time. And 2 to 5 days, I would say, is pretty modest, especially since I work in a big city area. We see people stay for 10, 15, maybe even up to 30 days waiting for psych placement. And the truth about that is that's because there are just not enough psychiatric beds to meet the needs. And while that is obvious more so in big cities, it's also going to be pretty obvious no matter where you work. So please note what's going on there. All right, first big question is, what qualifies as a psychiatric emergency? And this is pretty much when someone is in danger. The correct answer here is a danger to what? So the three biggest categories are a danger to themselves, and this is typically reflected in our suicidal ideation patients or our SI patients, and our suicidal attempts or SA patients. And then, of course, if you're a danger to others, you could have homicidal ideation or HI patients. And then lastly, those that have a grave disability or an inability to function in daily life. And that's usually our psychotic patients or psychosis, and sometimes even severe hallucinations. So the biggest three categories here are SI, danger to self, HI, danger to others, or severe psychosis or hallucinations, and that's that grave disability. So let's go through all three of these and talk about what you need to know. So the first is our suicidal patients. So there are two different main kinds of suicidal patients. The first is a suicidal attempt, and then the second is suicidal ideation or thoughts. So obviously a suicidal attempt is going to be more serious than a suicidal ideation because they've actually gone through some kind of action to complete the suicide. Now, that doesn't mean they've completed it, right? Because we're not treating dead patients here, but they've tried to do something to themselves to harm themselves. So this means that they're at a much higher risk. So this person is going to have to work a lot harder to be able to convince you that they're not a risk. So you got to ask yourself, or maybe even them, would the completion of the action that they took result in death? Now, this seems like a silly question, I know, but if they, for example, put a gun to their head, as is displayed here, that could, if they had completed that action, actually kill that person. However, if they took a plastic knife, you know, from like McDonald's, the ones without even the ridges, right? And they tried to stab themselves in the leg multiple times with this plastic knife, would that have resulted in death? Probably not. So that wasn't an actual serious attempt at suicide, right? And then the next question you got to kind of ask yourself logically is, why were they not successful? And the answer to this question also tells us how high of a risk they are, because if they weren't successful because they called the hotel office and said, I'm going to shoot myself in the face, that means that they're asking directly for help. They want to be caught. Now, this doesn't mean that you let them go, but this does mean that they're at a little bit lower risk because they didn't actually want to do it. Whereas if they happen to have the lawn guys that they forgot about walked in on them trying to tie the noose, that's probably a lot higher risk patient. So again, you got to use these logical clues and common sense to help you figure out how serious was this attempt. Now, ideation patients, you have to understand that there's also a very big difference between thoughts and intent, right? So if the patient comes in and says, my therapist told me to come into the emergency department anytime I had thoughts of hurting myself, and I've just had a lot of things going on in my life, and I've just been kind of in a deep, dark place right now, that's a little bit different story than somebody who said, I've been thinking about it for weeks, and I think I want to kill myself, and here's my plan, right? So you got to ask yourself, is this something that was said in anger? Were they trying to get their spouse or their parents' attention? And they were like, well, fine, if you're going to leave me, I'll just kill myself, right? Maybe that's not a true threat. So here's a couple of questions that I recommend that you kind of ask yourself or get the answers to in trying to figure out their risk, right? How far did they really go down this rabbit hole? How far did they really think about killing themselves? Are they thinking about it every day? Are they just wishing they could stop breathing? Because that's almost an expression of an emotion rather than some sort of action to be taken. Or do they have a plan? Is this plan something that is detailed or very reasonable? Again, we go back to the plastic knife from McDonald's. If that's their plan, probably not be a significant risk. Whereas if they have a detailed plan about how they have a backup if it's not going to work, maybe somebody who has 3 or 4 different things, or maybe it's somebody who's prepared. Maybe they wrote a suicide note, or maybe they paid 6 months of their electricity bill in preparation, or maybe they readied their will, right? How far did they go down this plan? Did they think about what it was going to be like to die from that Tylenol overdose, or what it was going to be like for their family after they died? Did they write a journal about it? So there's a lot of things here. I'm not going to go through all of them, but I really want you to go and dive deep into specifically how far they went in these thoughts and how frequently they're having them. Again, the best advice I can give you on these suicidal patients is use common sense and ask a lot of questions. Okay, you can kind of figure out who really wanted some attention and who actually is thinking very seriously about this process. I also want to beg you to read between the lines. Know that there's a difference between words, intent, and action. And this is probably the biggest thing that the psychiatrists depend on the emergency department for. And that is, you know, if a kid comes in and says, well, you know, I'll just go kill myself then, you know, did they actually mean that? Is that something that is an actual threat? The number of people who get referred to the emergency department for suicidal ideation because of an idle threat or words they said in anger that they didn't actually mean is very high. And you can screen these people out by asking all of these questions and using common sense. This also can be flipped, and people can say, no, I'm not really suicidal. And they have tons of action and tons of heavy intent behind their words. And they're just saying, no, I'm not suicidal anymore, so they can get discharged and go finish the job. So it's really important that you know that just because of what a patient says, that's different than intents and actions many times. So please use common sense for this. Now, I'd like to go through a quick patient scenario because these are very common patients that we see. So here is a patient scenario in which I have seen before. So I'm going to let you read it. I'm not going to read it to you. Now, there's a lot in this little scenario here. So the first big question is, how do we approach this patient? And I already told you that you probably need to be asking more questions than what is listed here. But for the sake of the argument here, most people can try to figure out whether they think this person is a real high risk to themselves or not. And I think that you could go through asking quite a lot of more questions about, you know, what stage of testicular cancer he's in, or, you know, why he doesn't want to go through chemo, that kind of stuff. But regardless of what you would do here and regardless of what I would do here, I think it's really good to be able to know how to chart these patients and how to legally protect yourself and figure out their true risk pattern. And so to do that, I'm going to show you 3 different categories that we need to go through on this patient and probably chart on this patient. So the first is going to be obviously risk factors. Now, a lot of you guys already know several of the risk factors, and I've listed several here in this picture. There are a lot more than are just listed here. For example, being male is a risk factor because males actually successfully go through suicidal attempts more successfully than females. That being said, not all risk factors are created equal, and it's really important you know that some risk factors are a lot more significant than others. Now, you also notice that I'm not listing something like SIG caps or SAD persons, which are both mnemonics for depression, because we're not talking about depression, we're talking about suicidal intention and attempts, okay? So it's really important that while many people are taught to do the SIG caps or the SAD person, that's about depression. And depression is a contributing factor, but we're talking about actual suicide here. Now, this leads us into going into the next category, and that is understanding that risk factors is not the same as warning factors. Now, this is a really hard concept for a lot of people, a lot of my students to understand. So I'm going to give you a little table here so you can understand. We're going to compare risks and warning factors for MI patients and for suicidal patients. So risk factors are often those things that we cannot change. So you can notice over here that when we're looking at some of these risk factors, right, you can see that a history of a mental health condition, that's something that you're going to have your entire life. Same with being male, or same with having a friend or family member that committed suicide. That's not ever going to change. That doesn't mean that you're going to go commit suicide every day of your life either. So if you look at my little table here, what you're going to notice out of this table is that a risk factor for having an MI or having a heart attack is smoking. So that means that every smoker is at risk of having a heart attack, but there are tons of smokers who don't have heart attacks, right? So if we're talking about suicidal ideation, having a history of depression could be a risk factor for having suicidal thoughts and suicidal ideation, But not every person who has depression is going to commit suicide, and that doesn't mean that they're going to do it right now. Whereas a warning factor for a heart attack is like having left arm pain right now. That's somebody who needs to be checked for having an MI right now, regardless of their smoking status, right? Same is going to be true about a warning sign of somebody who has written a goodbye note or a suicide note, right? That's somebody who needs to be evaluated for suicidal intentions right now. And the warning factors are really what we do in the emergency department. And so they carry a lot more risk than do actual risk factors. I know that doesn't make quite as much sense, but let's talk about the warning factors. These are the signs that we need to be evaluating somebody for true suicidal intent right now. So the first one is obviously a detailed plan. Now, a lot of people know, and they know to ask, do they have a plan? But you got to ask, how detailed is the plan, right? And how feasible is that plan? So if somebody says that they're going to walk in front of traffic, but they don't ever leave their house, that's probably not a plan that they can complete. So you need to go into the properties of each one of these factors and see how feasible it is, okay? Another action here is preparatory actions. So that means, did they go out and buy the bottle of Tylenol? Did they go out and register and buy a gun? Did they go out and practice tying nooses? Or did they go make a will? So there's a lot of different preparatory actions. I'm going to leave that to your imagination. What about impulsive decision making? So this is somebody who we're essentially saying we can't trust them and they can't trust themselves because they got drunk one night and they decided to jump off a 4-story building. That was an impulsive decision without making any planning whatsoever. That means that we can't trust them. All it takes is 2 seconds of being left alone and they're going to do something rash or impulsive. Another one is hopelessness or decreasing concern for the future, right? So somebody who's refusing to get the COVID vaccine because they're saying it doesn't matter if you get COVID because they're hoping to die. Or somebody who's saying, I don't need to save for retirement because I'm not going to be here for that anyway. Stuff like that. Next is a fixation on death or what it would be like to die. I've had a couple of people who have presented with journals talking about the experience of death or wanting to read every little piece of literature about what it's like to take that last death or what it's like to see somebody die. Those people are very big warning factors. And then again, increasing your risky behavior. So it's kind of like a decreasing concern for the future, but a lot of times psychologically, it's a separate behavior. So we usually see this by people who are increasing their drug and alcohol use or, you know, having a bunch of crazy sex or going to raves or just not caring about their future. And then finally, we get to the protective factors. Of all the different factors and all the different categories that we talk about, I think this one is probably the most useful. Now, you know that protective factors don't guarantee that this person isn't going to do it. It doesn't guarantee safety. But if you can document enough protective factors, this is somebody that you can say they're probably okay to go home with close follow-up. So I have listed here quite a few, but I want to talk about a couple more. And that is fear of actually dying, strong social support, like the friend or the parent or their spouse, dependence at home. Now this can be kids or pets, and then reasonable access to mental health follow-up. That's a big one. If they demonstrate hope or plans for the future, that's also a big one. If they have good plans for next holiday or what they are wanting to get for their birthday or et cetera, that's a big protective factor. And then finally, if they have true regret for what happened or what they were thinking. I have seen, not a lot, but a few people who did try a real suicide attempt, and they were so thankful that somebody accidentally happened upon them, and they were very truly regretful for what happened. This doesn't necessarily mean that these people all go home, but they are protective factors. So they're kind of the opposite of the warning signs and the risk factors for doing it. So let's go back to our patient scenario and let's go through all of our factors here. Let's go through each category and see if we can document this person's risk factors. So I want you to do it before I do it. So I would say some of the risk factors is that this guy is male, and he was diagnosed with a terminal illness like cancer. And he does have a history of previous mental illness. Remember, he used to take some kind of depression medicine, said his wife. So that's a big risk factor. I would say that's about all of the risk factors. Now let's move on to warning factors. So one big warning factor is he's increased his alcohol use because he's drunk today, 12 beers, right? And it looks like he has a plan. He wants to shoot himself in the head. Now, he doesn't have access, right, to a gun. So he didn't take any preparatory actions, and it's not a very detailed plan. Now, as far as protective factors, you can list in here the fact that he doesn't have a gun if you want to. He does have a son at home, and he has a supportive wife who really wants him to get help. So those are good things. He also really doesn't want to die. You can tell that by him saying he has so much to do. And finally, you know, he kind of has hope for the future in that he has things and plans for what he wants to do in the future. So we can say he has plans for the future. Now, based off of all of these different categories, this is something that always helped me try to figure out what is reasonable to offer this patient. Now, I want you to know that every person is going to be different, right? Every provider is going to have a different assessment factor. But for this patient, looking at his risk factors, his warning factors, and his protective factors, and of course, the fact that I can't go ask him more things, I might talk to him and his wife and see if he really thinks that inpatient therapy will help him. I can talk to him about what it's going to be like inpatient, and I can talk to him about, you know, treatments for testicular cancer, and maybe chemo isn't as bad as he thought it was, and see if he would reasonably be able to follow up tomorrow with a therapist if I gave him a list. This would be somebody that I would try to assess whether I could send him home with his wife watching him, or whether I really need to go ahead and admit this patient. So again, not everybody would come to that same conclusion, but using these three categories, specific emphasis on warning and protective factors, this is how I evaluate a psychiatric suicidal patient. Now let's move on to another category with the plan that we need to talk a little bit about drugs and psych. So drugs and psych, and I include alcohol in this, go hand in hand. And it's important that you understand that substances decrease our coping ability. So they decrease our ability to handle bad things. Now, if that's true, well, you might hear terms like drunkicidal or methicidal in the emergency departments. And these are people who are really drunk that instead of saying, oh man, I'm so sorry I'm drunk, you have people who are like, I just need to kill myself because I have nothing to live for. And they're not really thinking straight. The same can be true specifically with methamphetamine. And the same can be true with patients who have a true psych problem. So if they have a psych problem, like let's say they're hearing voices, Eventually, they might try to self-medicate with some kind of substance. And when they do this, they're going to get intoxicated. And then they're going to threaten, just like drunkicidal and methicidal, to kill themselves. Okay, this is when they end up in the emergency department. Now, what you have to understand is that because drunkicidal and methicidal is a thing, what we have to do is we have to wait until somebody sobers and they have the capacity and the coping mechanism to really tell me if you're actually going to kill themselves. Okay. Sometimes when they become sober, they're regretful and they don't want to kill themselves and they get to go home because they're sober and they now have the capacity. And sometimes what happens is when they get sober, they start hearing the voices again, or they start feeling the depression or the pain or whatever their psych problem is again, and then they want to kill themselves even more. So the important part here is that it's almost impossible to separate out somebody who has a psych problem and somebody who has an intoxication problem. And you don't, and I don't have the ability to differentiate the two, which means that you're going to hear the phrase, sorry about that, I got to clean those up here. You're going to hear the phrase metabolized to freedom. So this means that we cannot medically clear patients until they are completely sober from whatever medication that they're taking. So they sleep it off, the alcohol or the meth or whatever it is, and then they get reevaluated. After they get reevaluated, if they are still suicidal or if they still have a danger to themselves or others, that's when then they can be found placement for, rather than somebody who is still intoxicated. Intoxicated patients do not have an accurate evaluation. And this is the final special caveat to the suicidal patients that I want to make sure you're very aware of. And that is those patients who intentionally cut. Usually it's the wrists, sometimes it's the thighs, sometimes it's other areas of their body. Now, you need to understand that they had to hold a sharp object, whatever it was, to their skin and cut multiple times usually. When they did this, a lot of cuts are very superficial. They're just enough to cause a scar or a scab. And this isn't a protective factor, but it is a different thing than trying to kill themselves, because they had the intent and opportunity to stab themselves deep enough to cause death. And yet they didn't take it. They didn't take the chance. So what we found about cutting is that cutting indicates that this person has some poor coping skills, but usually they're not seeking death. Usually they're seeking escape. Usually they want that physical pain to escape from situations or feelings. Sometimes with some teenagers right now, it can be very attention seeking, where they'll take pictures of this and post them on Instagram, which is absolutely ridiculous. And sometimes it's even peer pressured. A lot of the goth kids see having multiple scars on your wrist as an identity. So this is something that you need to do a lot of investigation into. But you also need to know that while intentional cutting needs psychiatric care and they shouldn't be ignored, this is often not, I repeat, not the same thing as a suicidal attempt. This is usually more of a cry for help than anything else. Now let's talk about homicidal patients. So homicidal patients are considerably rarer than suicidal patients. And you also have two different kinds of homicidal patients. The first is a homicidal attempt, and then the second is homicidal ideation. Now, the truth is, in the emergency department, we don't see too many homicidal attempts because safety and staff safety is our very first priority. And so if somebody has been caught trying to kill someone else, this person should probably be in jail rather than in the hospital, right? This is a person that is telling us that we can't trust them with another human being. So this is not for us to try to determine if it's a psych cause or not. That's for the judge. So if somebody is being brought to you for attempting to kill someone else, they need to go to jail and they can see a psychiatrist in jail. For homicidal ideation, again, you need to ask things about specific details about homicidal ideation. So is this a group of people or one particular person, right? So some of these psych patients come in and they just want to kill everyone. And they don't know how or why or who. They're just like, everyone, you and you and you and you, and I just want to kill things. That's, again, not necessarily a truly homicidal patient, right? More of a truly homicidal patient is somebody who wants to kill a specific person. Then you need to ask, do they have reasonable ability to complete that action? So if somebody wants to kill the president, but they live in California, that's probably not likely, especially because they don't have money for a plane ticket, right? And if they don't have a plan for how to kill the president, like if they say, well, I want to do it with a gun, but they're homeless, they're probably not going to get a gun, all right? The other thing that you have to find out is how close they were to doing it, or are they just talking, right? So if somebody says, oh yeah, I'm going to kill you, you know, you talked to my girlfriend wrong, that may be like a real threat, but not necessarily a true intention. Again, that whole words versus actions thing. You also want to try to figure out if homicidal ideation has psychotic or delusional features to it, right? So a lot of patients who are truly psychotic will often think that the government is attacking them or following them in FBI vans, and they want to kill somebody because they don't want the government following them anymore. So this is not reasonable logic. And that's somebody who probably needs to be watched because they're not following logic, right? You also maybe need to find out whether that delusional person actually has the ability to harm someone else. I had a patient somewhat recently who said he wanted to kill people with a machete. And when I pointed out that he did not have a machete, he said he was going to stalk people at the mall until he found somebody with a machete, follow him home, kill that person with his own machete, and then kill himself with his machete. Now, this doesn't seem very reasonable to me because you can't go to the mall and ask, do you have a machete? Do you have a machete? Do you have a machete? And then when somebody says yes, they don't notice me following them home. So this is not somebody that I kept for homicidal ideation. This is somebody that I evaluated for psychosis. I'm sure you get the idea. Okay, let's talk about psychotic patients. So true psychosis is, by definition, somebody who is responding more to internal stimuli than external stimuli. So these are patients who are usually hallucinating or talking to somebody who's not there or babbling nonsensical, non-logical things. And what you have to do is you have to determine whether this psychosis causes them to have an inability to handle their daily life, or ADLs. That's activities of daily living, activities of daily living. So this means that, can they dress themselves? Can they take their medicines? Can they find food? Even if that means going to a church or soup kitchen. Can they go to work reliably? Or can they make their own decisions? Can they even function with the outside world? There are many patients who hallucinate, who do have the ability to handle their daily life. One of the most common patients that we see are patients who believe delusionally that somebody is coming into their house and poisoning them while they sleep, or dissecting them while they sleep, or is, internally changing something in their house while they sleep, and they're very afraid. A lot of these patients will present to the emergency department because they've called 911 something like 20 times a day, right? These are patients who have their own apartments, who can get to work reliably. They are functional. And unfortunately, a lot of the delusional patients are not somebody that we can hold against their will because they are not gravely malfunctioned. And if they choose not to take their medicines, we can't do anything about it. So for these psychotic patients that we need to hold against their will or to actually evaluate, you need to be able to document a couple of things to be able to keep these patients. One of them is that you need to be able to document that they're responding to internal stimuli. So again, they're not responding to things outside their body, they're responding things to inside their body. It's a fancy medical way of saying that they're definitely hallucinating, right? Either auditory or visually or something. Some people will like try to grab at things or talk to things that aren't there. You can also use the term tangential or circular thinking. So this means that they can't go in a linear progressive pattern that follows logic. Sometimes this means all they can do is sit there and chant. Sometimes this means that they're kind of all over the place and they're not really answering questions. You also want to be able to document whether they're directable or redirectable. So if you say, yes, but sir, but go back to that van that's following you. And then they're like, oh yeah. And then they talk to you about the van that's following you. That's redirectable. Redirectable is something that is somebody who is usually able to function their daily life. Whereas if they're not redirectable and they just talk nonsensically, no matter what you ask them, that's probably more of a person that needs to be gravely disabled, right? And then some patients, you need to talk to them or you need to be able to document about how much they're following commands, right? So if you ask them, be like, okay, give me your arm for blood pressure, or do you want a Sprite or a soda, or a Coke, and they pick one, that's them following commands. So you need to document what percentage of the time they follow commands. Maybe it's only 10% of the time, or maybe it's 50 to 75% of the time. And you have to be very careful with this because sometimes you have to be tricky about getting them to respond to you logically. Some homeless patients want to be admitted, and so they try to fake being psychotic. Not everybody, but some patients. So you want to be tricky about when they're responding and when they're not, and you want to do things that are not always something that they can anticipate. All right, so now we got to ask, why are these psych patients, even when in emergencies, ending up in the ER rather than a psych hospital? And the answer is that they need and require medical clearance. And the other answer is that there aren't enough psych hospitals to manage all of them. So let's talk a little bit about medical clearance, because medical clearance is a bit of a misnomer. It doesn't mean that we're clearing them of all medical problems. It means that we're ensuring that there isn't a medical cause of their psychosis or psychiatric symptoms, right? So if there's no medical problem causing their psychiatric symptoms, they have medical clearance, despite the fact that maybe they're hypertensive, or maybe they have a urinary tract infection, or they can have an innumerable amount of medical diagnoses. But medical clearance just means that there's no obvious medical cause of their psychiatric symptoms. All right, so let's talk a little bit about what we're ruling out. Now, usually this involves understanding the difference between organic and psychiatric problems. So let's go through some real psychiatric problems that cause psych issues, right? So one of the most obvious big ones is schizophrenia. Now, there's a bunch of different kinds of schizophrenia, and we have all the different ones from schizoaffective disorder to schizotypal, that's a personality type, right? Or you can have schizophreniform patients. So any of the schizo patients would fit into this category here. Now, what about people who are not schizophrenic? Remember that we're going to have delusional patients, and they have to be unable to do their ADLs, or activities of daily living. And a lot of times delusional patients are mostly harmless other than they call 911 too many times. You cannot admit those patients. You cannot hold them against their will. And a lot of times you can't talk them out of their delusion. So it's important that you know that while they are true psych patients, we can't do anything with them. Now, another maybe more obvious or more general causes of psych issues that can cause these people is like a PTSD patient, especially one with recurring nightmares or dreams or inability to distinguish reality. Then we also have those folks with an acute, psychotic break, too much stress, or maybe somebody who has a stress type reaction who can't handle whatever's happening. What about somebody who has a hormonal issue like postpartum depression, right? That's actually considered a true psych problem. And aside from postpartum depression, I would also add in to any of the mood disorders here. Now, last, we got to add in some psych issues secondary to drugs, right? That is definitely something that can be in the psych category. Now, what about the organic or the medical problems that can cause, like these are the things that we're actually ruling out, okay? So if that's the case, we gotta make a list, and you gotta consider drugs and alcohol, and especially if they get sober and then this psych stuff is gone, drugs and alcohol are one of our biggest medical reasons why they're experiencing hallucinations or suicidal ideation, right? These are the drunkicidals or the methacidals. Now, one of the biggest categories here is also probably some kind of brain pathology. So it could be a brain tumor, right? That can cause people to hallucinate. What about somebody who has a brain bleed? We don't want to forget those folks. What about the folks that are having some kind of stroke? Or even people who have some kind of TBI or brain injury. Those are all people who can have a medical cause causing them to have some sort of psychiatric issue. I also want to add in here some kind of infection. So with old people, a lot of times they can have a urinary tract infection, or you can have somebody who has HIV that's causing them to hallucinate and have more issues, right? What about somebody who has some kind of weird prion disease? That's obviously rare, but it's something that you got to consider. Okay. Now we also got some other causes here. We got people who have temporal epilepsy. Temporal epilepsy is somewhat rare, but does cause hallucinations right before their seizure. We also have another rare cause, Huntington's. Sorry, that's my dogs barking. What about all the different kinds of dementia that lead to hallucinations? So I'm talking about Pick's dementia or Lewy body, right? There's tons of different dementias that can cause that. What about normal pressure hydrocephalus, right? What about like hormonal issues, like problems with your thyroid, or you could even have problems with like Cushing's and your cortisol. What about causes of encephalitis? Now, encephalitis could be maybe a high ammonia level from having liver failure, or you can have uremia from problems with not getting to dialysis quickly enough. What about HIV encephalitis? We kind of talked about that when we talked about infective causes. And hey, we got to go back down here and add Lyme disease to infection. Lyme disease is very well known for causing encephalitis and hallucinations. What about Wernicke-Korsakoff, right? Wernicke's, that's an encephalitis. And finally, there's a couple other rare ones like Wilson's disease. Wilson's disease is having too much copper build up in your liver. I think there's one with too much iron as well. So you get the idea. There's tons of these different organic or medical problems that can cause your psychiatric issues. And so when we talk about medical clearance, we're talking about ruling out this side of everything. Okay. Now, obviously, we can't do every single one of these in the emergency department, but what we can do is we can look for hints and clues to be able to clear them out. So let's talk a little bit about the typical psych order set. But before we do that, I want to make sure that you know that you do not have to order everything in a psych panel to medically clear these individual patients. Not everybody you're going to be worried about is going to have to be ruled out for dementia, probably because, they're 35, right? Not everybody needs to be ruled out for prion disease, okay? Not everybody needs to be concerned with Huntington's, right? So we don't have to order everything in our order set. But the administrative truth about this is that most psychiatric facilities won't accept patients without as many labs as we can order. So it's important that you know that even while it may not go against, or it may go against logical sense, if you decide that a patient needs to go to a psychiatric facility, you do have to follow your facility's policy because those psychiatric facilities get to set the rules. So let's talk about what's in a typical order set. So we start with some of the basics, and we got to prove that, their alcohol level is less than 100, because remember, they won't take it if they're drunkicidal, right? And we do UDS to make sure that they're not on a bunch of drugs. And then recently they've added a couple more, like pregnancy, COVID, and a CK level to rule out rhabdomyolysis. Now, I have seen some psych facilities that add special things. For example, EKGs, thyroids, and a lot of times they want a Tylenol and a salicylate level to make sure that they just didn't overdose on lots of medication. That's usually for suicidal attempts, right? So this is generally a pretty decent workup. You should definitely know what your facility requires you to do, and some facilities will require extra things. So now we get into the general approach for psych patients. So I want you to realize that there is no standardized, perfectly reasonable approach to psych patients. So what I've done is I put about 6 steps together to kind of give you some tips and tricks on how to manage some of these psych patients. But this is my approach and my practice, and it definitely doesn't apply to every single patient that I see. But I wanted to give you some general guidelines, so let's talk about it a little bit. So the biggest #1 thing that I can tell you is read the room. When you're dealing with psych or intoxicated patients, safety is the priority. Your safety and your staff's safety is priority over the patients even, which seems kind of rude, but they're the ones that are in this dangerous situation. And if you're going down, you're just adding to the patient load that's happening. So spend time and observe the patient outside the room, okay? If the patient is thrashing around and being held down by 4 or 3 police officers, maybe now isn't the time to go in. Maybe give them a little bit of time. Know what you're walking into. I also want you to know that the provider is not the jailer. So don't wrestle or fight with the patient. That's not your job. And you just need to leave or extricate yourself if you can. You should call security or the police for that. I also want to make sure that you know, never let the patient between you and the door. You need to always make sure you have a quick exit. So if the patient is pacing around, get them to sit, or make sure you stand right by that door. Do not let even seemingly innocent patients getting between you and the door. Things can change on a very sudden basis. So please remember that. Now, number 2 is kind of the hardest to explain, and that is really setting clear boundaries and knowing when to walk away. So I have 2 different examples for this. The first is you want to kind of set the rules for acceptable behavior. Now, I know that we work in the emergency department and not very many of you are offended when somebody cusses. But if you set clear boundaries for these psych patients, they do a lot better than when you don't. And this has to do with, a lot of the personality disorders and stuff like that. People, especially psych patients, need structure. And where I'm working in the South, you don't cuss when there's a lady present. And so if the patient is being unacceptable, like cussing or shouting or spitting, I give them a warning once and say, you need to stop that. And if they do it again, then I get up and leave. And they're stuck there until I see and talk to them. So that might not mean I might not get back to them for hours and hours. So I don't go in telling them the rules, right? I don't talk to the patient that way, but I do start saying that if they start treating me with disrespectful behavior, I give them one warning and then I get up and leave. Now, my second example is if you have an intoxicated patient or a psychotic patient, and after talking to them, asking them 2 or 3 questions, you realize that they're just chanting, or they're not answering questions, or after kind of officially agitating them, they're talking about willow branches or something. You got to understand and know when to walk away. You ask a couple of questions, you agitate them, you try a couple of different things, but if they're too psychotic or too hallucinatory or too intoxicated to be coherent, don't waste your time, get up and walk away. Come back and reevaluate at a later time. I also have to make sure that all of you are aware that psych patients are incredibly manipulative, and that it's really important that you don't fall into their traps. A lot of these patients, whether they're drunk, intoxicated, or homeless and psych or whatever it is, they can be very manipulative. And so if they're saying something to make you mad, or if they're trying to get some kind of arousal out of you, don't show it. Try not to have too much emotion other than, well, I'm sorry to hear that, or, well, that's not how we do things here. Be extra professional. If they're cursing your future unborn children or grandchildren or whatever, it doesn't matter. Understand that the minute that they get some kind of emotional response out of you, they're winning. So never shout at your psych patients or your drunk patients or your high patients. It doesn't matter how mean they are. It doesn't matter how loud they are. There's no excuse. So if you're not getting through to them, walk away and go back later. If they're trying to get you to break the rules or be extra nice to make an exception, remember that's also them trying to manipulate you. So you can be manipulated with anger, just like you can be manipulated with compliments and flattery. So beware of these patients, beware of manipulative behaviors. I always document in physical exam, patient is displaying manipulative behaviors, especially because many of the patients will demonstrate black and white. Like, oh my gosh, you're just the best doctor I have ever had. And then the minute that you do something they don't like, you're just the worst thing that has ever happened in my whole life, right? So you have to understand that in psychiatric care and in substance abuse problems, structure is important, and do not respond emotionally. This does take practice. Okay, number 3. So obviously we need to get a history from these patients. And the truth is, I know that sometimes this can be very difficult. So aside from those acute psychotic patients who are hallucinating and unable to answer questions because they're incoherent, if they're just agitated, one of my hints is that you need to offer choices and barter with the patient. And here's what I mean. Are you hungry? Would you like a Coke or Sprite? Or maybe a turkey sandwich versus applesauce, right? Or would you like a blanket? We have warm ones. Are you cold? Do you want to talk to me by yourself, or would you prefer the nurse stay with us? So notice that none of these are big choices. All of them are small choices. I don't give them choices like, do you want to stay or leave? Or do you want to talk to me? I give them offer little tiny choices. And this is to give them some of the appearance of having control over their lives. So you have to understand that especially psych patients, even if they're homeless, they have not been in control of any part of their lives for a while. And this is going to be true, especially if they were brought in by the police and they were fighting. What you want to do is you want to say, oh, I know you're a good person and you didn't mean it. I'm safe with you, right? Or why don't we give you a little bit of time and I'll go get you something to drink. Do you want a Coke or a Sprite? Giving them these little choices gives them some ability to have some control over what's happening to them and will often make them calm down and listen to what you're saying. Now, I also realize that if they've been spitting and throwing things, you shouldn't give them a Coke or Sprite because then they're going to throw it at somebody and hurt somebody. So then you can say, well, you can talk to me now, or I can give you 10 minutes and come back later. And maybe that means they flip you off and then you say, okay, that must mean that I'm coming back later. Sometimes it's those little choices that will eventually get them to calm down. You can also barter and say, well, I'll let you make one phone call, but only after you let me get vital signs and talk to me for 5 minutes, right? So that's what I mean by offering choices and bartering, because it gives them a little bit of control back. Now, again, this doesn't apply to every patient, but it is something to have in your tool belt. Another big secret is being on their side. Now, believe it or not, a lot of these patients are used to being marginalized. They're used to being ignored. They're used to people being afraid of them. So if you sit on a stool in front of them, unafraid, and say, tell me what's going on, outside of having the police standing there, and you're actually listening, sometimes just listening to them is enough, that they will tell you everything you need to know, and then they'll feel much better. It's also, especially in patients who are truly psychotic, important to try to believe their delusion for at least a little bit. And the reason I recommend this is because, one, you're not going to be able to convince them that the FBI isn't following them in the police van, but also because if you play along for a little bit, they will tell you everything you need to know. I did have a very well-known delusional patient who told me that somebody was coming into his house in the middle of the night to dissect him. And he knows this because he gets put back together every morning, which obviously doesn't make very much sense. But when I asked him how he knew which part of his body was being dissected, he ended up showing me all these little cuts on his feet. And he ended up having a whole bunch of impetigo infections all over his feet and probably some bed bugs. So he had a medical problem, but his delusion made him think that there was something else going on. So sometimes you need to listen to the clues, because medical problems can be disguised. So it's worth your time to listen to what they're saying and believe for at least a little while, or point out logic problems and say, well, how do you know this happened, right? Remember that you're not going to be able to cure those delusions or those hallucinations anyway. And finally, number five. Number five is probably the hardest thing to do. And this is really where the art of managing psych patients comes in. And that is to be able to differentiate these three categories. So it's our job to differentiate organic or medical problems versus psychiatric problems. And a lot of that has to do with the lab work that we order, right, for medical clearance. We also have to differentiate competency and capacity of these patients. And then the hardest one is statements versus intention. And that usually takes quite a lot of time. You have to investigate this patient and try to figure out what do they actually mean versus what they're actually saying. Kind of like we talked about with those SI patients. You also need to understand that these patients can be sick too. So initial assumptions can be wrong. Just because they're homeless doesn't mean that they don't have a brain bleed. Just because they're acting crazy and being an asshole doesn't mean that they don't have some kind of medical problem that's actually causing this issue. So it's really hard to hold off those initial assumptions because that's what we're taught to do in emergency medicine, which is why you have to be very careful when approaching these psych patients. All right, here is a little chart or graph that is often quoted, especially on tests, about differentiating organic or medical causes with psychiatric causes. And one of the biggest ones I want to point out to you is the onset. So if this is acute and this changed within the last few days, then it might be a medical cause. Think about old people with UTIs and suddenly they're hallucinating, right? That's probably not dementia, it's probably a urinary tract infection. Whereas if this has been a slow, gradual thing, this is probably more psychiatric. Psychiatric diagnoses tend to be in the ages of 20 or 30, right? Somebody who's 60 probably doesn't develop schizophrenia suddenly, right? You also want to note that both categories can have hallucinations and both categories can be impaired intellectually, right? So those are probably not reliable to figure out whether it's organic or psychiatric. The same is going to be said about vital signs. Even though it says psychiatric patients have normal vital signs, I haven't seen one homeless patient who has normal vital signs, probably because I live where it's hot, or because they take drugs, or because whatever the problem is. So vital signs is not reliable either unless you've kept them in the hospital for more than 24 hours. So I would start with looking at things like onset to really sort of figure out for you the difference between organic and psychiatric. And I relied pretty heavily on my physical exam and my labs. Now, we do need to talk about competency and capacity, and I recommend that you don't use this lecture as the only thing that you're learning about competency and capacity, because I am not the main person for this. But when we talk about does somebody have capacity, this is a legal term. This is something determined by a judge, and this is when we talk about somebody who is too demented to make their own decisions, right? The ER doesn't have any say over their competency. And we do get more than just the elderly with this. We'll get patient family members who keep doing drugs or keep drinking alcohol. And they say, how can we force them to stop? How can we force them to go to rehab? And the answer is we can't. Unless a judge declares it required, legally we have no ability. What we do have ability over in the ER is capacity. Capacity is a medical term for their ability to understand the consequences of their decisions. Now, you also need to know that this is a fluid concept, which means it changes almost moment to moment, hour to hour. So that means if somebody comes in drunk, right, so their alcohol level is ridiculously high, they probably don't have the capacity to decide if they want to take their own life. And then once the drunkicidal goes away, AKA they metabolized it away, and now they're no longer drunk, they're sober, then they suddenly have capacity again to decide what's going on. Okay, the same is going to be true about medical patients. Let's say somebody comes in and they're acting a fool and they're being really jerky, and we turn out that we need to get a CT scan and they have a big old head bleed. okay? They didn't have the capacity to consent to a CT scan at that time, which is why we had to give them medications. And then after the CT scan, if the CT scan is normal, they get to decide if they want to leave or not, right? So capacity is the ability for this person to sign out AMA and understand the consequences. So you're allowed to make a decision that we don't agree with or defies logic, but we have to be able to prove that you understand the consequences. And this can get pretty sticky. So it's really important to understand the difference between capacity and competency, especially when we're talking about who can sign out AMA and who cannot. Now, my last big tip when dealing with psych patients is accepting the things that you cannot change. So this is kind of sad, but psych patients and the ER and substance abuse is sort of where social problems meet medical problems. And the truth is that not everyone wants help, and not everyone who wants help is able to be helped. So that means that sometimes insurance or payment is an issue. Sometimes heroin addicts want to get off heroin and go into drug rehab, but it requires insurance or money they don't have. Sometimes people want out of abusive situations, but we don't have room in the women's boundary shelter. Or they want to get off the streets and no longer be homeless, but we don't have the programs for them right now. There's a lot of different things that happen socially that people who want help end up in the emergency department, and you have to learn to not take these things home because some things we can't change. And you got to live for the people who we can change things for and we can help. So now let's talk about how do we contain agitated, violent patients. So the real answer is we got to start by attempting to calm them, which means don't jump straight to chemical or physical restraints. So we got to define how agitated they are. And I listened to a lecture once of a gentleman who kind of defined the agitation spectrum as we have the agitated cooperative patients. They're agitated, but they'll do what you say when you can go in the room and make them do it, right? Then we have the disrupted, nonsensical patients who are very disruptive, but they're not making a whole lot of sense. And then we get into the seriously scary patients, the excited delirium patients, and finally, the non-logical violent patients, okay? So pretty much at the half mark is when we start getting worried. So whenever possible, you always want to start with physical restraints. But before you do that, you need to set up a calm atmosphere and at least try. So there's a couple of different tips that I have here. The first is as few people as possible, especially for truly psych patients. Being crowded by police or physically held down, your first instinct, even children's first instinct, says fight and get worried and yell and scream and bulk away. So even if they're drunk or substance abuse, maybe what you need to do is get as few people in there as possible, and that can calm them down, right? You also want to remember that third rule and giving them some control or choices, right? So obviously if they're being held down by police, now is not the time to offer them food, but you can always offer them something else. Give them some kind of choice and say, well, if you calm down, I'll take one restraint off. Or if you calm down, we'll leave the restraints on, but we'll ask the police to leave. Like I said, you can combine these and maybe give them a trial of one restraint free or asking the police to leave. Now, of course, you also need to monitor your tone of voice. You need to acknowledge their emotional upset and maybe how unfair this is, or you need to allow for them to have some personal space or silence. Because remember, they've been shouting and people are holding them down. And for many psych patients, especially the schizophrenic, this can be really overwhelming, okay? Now, obviously, you need to have consequences for the actions that are happening, right? So if you give them a trial of restraint or police free time, and yet they're yelling and spitting at you, the police are going to come back in, or you're going to leave, or both. So some patients, it's worthwhile trying to give them a calm atmosphere, maybe even dim the lights. But if calming doesn't work, or if they start fighting again, you might need to go ahead and do some physical restraints. Now remember, it's really important to know that there's a right way and a wrong way to do physical restraints. So you want the patient to be prone, not supine, right? We don't want to cause airway issues. We want it to be in full 4-point restraints, not 2-point, where they can hurt themselves or other people. If possible, you want them to have one arm up and one arm down, because that's the most comfortable and the most restraining way to put somebody. You also want to use quick release knots, because you never know when you need to intubate one of these patients. And you can use a mask to prevent them from spitting at people, right? So you don't want to use the 2-point restraints. Notice that the head of the bed is elevated just a little bit, and we're not using a pillow because they can hurt themselves or cause respiratory problems with a pillow. We also don't want to tie them to the bed rails. We're tying them to underneath the bed because that's where it's meant to be tied. And we don't want to restrain the head. Even if they start banging their head on the bed, please don't restrain it, because that can cause more problems than it solves. We also need to reevaluate and redocument every hour once somebody is in physical restraints. This is a rule, so that way we're not physically restraining patients all the time. I don't know why they think that this is fun for us, but every hour you have to put in a new note. Some hospitals have every 3 hours, but you have to reevaluate and see if they're calm and cooperative, can we let them off the physical restraints or not? And if they're very violent, physical restraints aren't going to be enough. So if the patient keeps banging their head, you might need to go to chemical restraints. So let's talk about chemical restraints. I have 5 different medicines in a spectrum here. And of course, if the chemical restraints don't work, you might need to go to intubation. But we always start with Ativan. Okay, Ativan is the most calming, and remember, it's going to work on patients who are withdrawing from any kind of substance or any kind of toxin, and you can give it in both oral, IV, and IM. The next drug of choice is going to be Haldol. Haldol and Ativan are one of the most common combinations. They usually call it the 2+5 or the 5+2, and that means 5 of Haldol and 2 of Ativan. Now notice that Haldol has a little asterisk next to IV, and that's because Haldol is technically not for IV use, but it's been used that way for so long that nobody blinks an eye at it anymore. The next medicine that we all like is Geodon. Geodon is an antipsychotic medicine that's very sedating. Now it does take about 5 to 10 minutes to mix. So if the patient is really causing a scene or a ruckus, using a little bit of Ativan before you go to Geodon might be the better option. But I've gone to Geodon with lots of different patients, especially the intoxicated patients, because Geodon makes almost everyone fall asleep for quite a few hours, which can be a really big relief and give them time to metabolize off whatever substances they've been taking. Now notice that Geodon can only be given IM or IV. It's not an oral one. And obviously if the patient is fighting, they're probably not going to take oral medicine anyway. Next is Zydus. Zydus is also olanzapine, which is another antipsychotic. Zydus is of particular use for people who are hallucinating. And usually we only give it orally or IM. So if somebody is hallucinating up the wind wing, instead of making them sedate, what I'll usually do is I'll give them some oral or IM shot of olanzapine and see if that fixes the problem after about 5 minutes. Now, obviously, olanzapine or Zydus is not to be used in the truly violent patients at the end of the spectrum, like if they're hurting themselves or other people, if it's taking 5 police officers to hold them down, this is not the medicine to use. This is for somebody who you say, will you take a medicine? If you take a medicine, we'll let the police leave, right? We're going to barter that system with them. And then last but not least is ketamine. Ketamine is used in only the most violent, non-logical patients I have, and I usually only use ketamine if I'm trying not to intubate the patient. And we're talking about those truly disruptive patients where Geodon and Ativan and all of those haven't worked. So we're going to give them a ketamine dissociative, which can sometimes make the patients even higher. Now, there are a couple of alternatives that you should know about. A lot of hospitals don't have droperidol anymore, although a lot of people prefer droperidol over Haldol, and midazolam is preferred sometimes over Ativan. Not quite sure why, but both of them are good medicines. So you always want to start with a benzo if possible, but benzos work very quickly. So if after 2 to 5 minutes a benzo is not helping them sedate, you need to either go to Haldol or Geodon. It is important that you know that we do not recommend that you use Haldol with Geodon. You usually use one or the other, not both, okay? And then this is, Zydus is for our patients who are awake and somewhat compliant, right? Now, there is a big negative to chemically restraining these patients. One of the biggest negatives is that you cannot medically clear this patient, or the psych facilities or psych services won't evaluate the patient until they're woken up after you give the medicine. So you're pretty much guaranteeing that this patient is going to be sleeping in that room for at least 4 to 6 hours, if not longer, based off of these medications. That's also a reason why you don't want to jump immediately to intubating a patient, because again, they won't be evaluated until they are completely awake again. So if you need to get a head CT to make sure you're ruling out a bleed, then yeah, maybe you should give them some Geodon, or if they're harming themselves or the staff, that yeah, they probably need some medications, but you have to give them just enough so that way they calm down, which is again why we start with Ativan most of the time. Now, it's also worth noting here that old school medicine, for any of you who have been around that long, used to give something called B52. So you're going to notice that 5-2 again, which refers to Haldol and Ativan. The B stood for Benadryl because they wanted to ensure sedation. However, it's really important that you know that B52 is really fallen out of favor. We don't give it very often because of the Benadryl, especially because of how sedating this can be. There have been instances of people who have stopped breathing or not noticed that they stopped breathing, or there's been a lot of instances of people who didn't get their head CTs, or any psych patient just immediately gets B52, which is inappropriate. So for whatever reason, we don't teach B52 anymore. We start with Ativan, and then you either choose Haldol or Geodon, and that tends to be the chemical restraint of choice for most emergency departments. Now, what to know about holding patients against their will? The most important part is this is a state by state, county by county change. So your state's rules could be different than mine. So let's talk about what we know about putting somebody under an involuntary hold. Some people call it a 5150, which is, I guess, the number of the law that allows us to involuntarily hold a patient. Also, it's called an EDO, or an emergency detention order. So this is an observation period to allow for either psych evaluation or medical testing. Okay, so this does not require the patient to do treatment. And it doesn't require, other than for chemical restraining, they do not have to take any psychiatric or treating medications. This is the same for if we find out a patient has a head bleed, they aren't required to get treatment for that head bleed. Weird, I know. Now, it can't be any longer than 72 hours, and that is defined by federal law, so that's true across the board, all states. And you cannot hold somebody if it's not an acute problem. So just because they've been schizophrenic for the last 20 years doesn't mean that you can hold them involuntarily because they're not taking their medicines. Okay, this has to be an acute episode for you to hold them and initiate the hold. Now let's talk about which patients can be held against their will. So it's important that you know that it's not just psych patients. Anyone who doesn't have the capacity, which really means that they don't understand consequences, and they might have a life-threatening cause of problems. Now this is kind of a iffy issue in the law because it's not very clearly defined. But if somebody is drunk or intoxicated, and maybe they had a car accident or they fell from a building, just because they're not a psych patient, but they're drunk and they don't have capacity, you can hold that patient until we can get a head CT. Now, again, there's a lot of I guess, gray area here. But if you can say, if you have this head CT and it's negative, then you are allowed to leave AMA, sir. A lot of times that will make the patient go ahead and allow us to do the head CT, and it shouldn't take too long, right? You also have to know that it can't be just any psych patient. Just because they're a psych patient doesn't mean we can hold them against their will. It has to be not just an acute problem, but we have to deem them a harm to themselves or others, or have a sudden grave disability, right? They can't do their activities of daily living anymore. So that means that that delusional patient who thinks somebody's breaking into their house and they're calling 911 20 times, that's not somebody that can be held against their will. So you have to look through their history to determine whether they're a harm to themselves, others, or have that sudden grave disability. Now, there's a couple of unclear questions, and these are not the only ones that I have about involuntary holds, but some of the unclear questions that nobody knows the answer to are, is their observation period completed if the ER doctor does the psych eval? Like, by that, it means that we do the lab work and we medically clear them. Does that mean that they get to leave? We don't know, and each facility has a different rule for that. What about, is it required that we release them if they have to wait more than 72 hours for a psychiatric placement? Or do we have to wait until the psychiatrist says they can be released? Again, some of these patients wait 5, 10, 20 days in the emergency department waiting for a psych bed. Can you release somebody after 72 hours once we know that there's no medical cause for this? We don't know. Now, here's another big question. Who can issue an involuntary hold? So there's a lot of different people who can issue this. There's a judge, of course. There's the physician, and they don't really define whether an NP or PA can do that, except in a few states. So a lot of hospitals will make the physician put in the hold. Sometimes a mental health deputy, and I'm not spelling things right, but you know what I'm saying, mental health. Whoops. So anyway, there's a bunch of different people who can share this and who can issue a hold. And now that you know that the rules vary by state and country, here are some examples. And this was from a paper that was done in 2018, I believe, that of the different states and who can issue a involuntary psych hold on certain patients. And what you can see is that it's very varied. Look at how many states can say any interested party can issue a psych hold. That's a lot of different states that let anybody issue a psychiatric required involuntary evaluation. And look, Arizona lets a friend do it. A peace officer seems to be pretty popular in a lot of states, as is a physician, but notice that not all states allow a physician to do it. So that's kind of a little strange also. So you can see that the Nurse practitioner and physician assistants are only in some states, and only some states allow a psychiatrist or a mental health professional to do it. Again, not every state says the psychiatrist or mental health professional can do it. So if you're in a state where a physician and a psychiatrist can't do it, sometimes you have to have a police officer do it. Sometimes you have to have a peace officer do it. Notice that even in Hawaii, an attorney has to do it. So there's a lot of different states and a lot of different rules. Feel free to look up your state if you want to, and know that these laws do and can change based off of the fact that this particular graph and table was put together in 2018. So let's go through a couple of quick questions that I want you to pay special attention to the answers for. So can a patient who's under an involuntary hold refuse treatment? The answer is absolutely yes. Remember that an involuntary hold only requires an evaluation. So they have to do and consent to medical tests, but they do not have to consent to treatment. So you cannot force them to take the treatment. Can a patient under hold sign out against medical advice? Again, tricky question, but the answer is sometimes yes. If the patient has capacity, so they're not intoxicated and they understand the consequences of their decisions, and if their labs are normal, in some states, the answer is yes, right? Maybe they've been waiting there for 5 days, or maybe the lab work has come back negative and they're not high and they want to go home. In some states, that's allowable. So you got to make sure that you know what your state's rules are. All right. Lastly, what else do you need to know about psych patients? I only have 2 more big slides for you, and that is about pediatrics and discharge. So when we talk about pediatric patients, specifically psych pediatric patients, kids have less control over their lives, right? Because their parents get to make all their decisions. And there's a lot of kids out there that have a lot of abnormal family dynamics, and there's a lot of hormones going on, so they can have overly dramatic responses or a lot more attention seeking and peer pressure. And recently it's been really more obvious that there's a lot more cyberbullying that's happening in schools. So kids have a lot of different issues than do adult psychiatric patients, and you should be aware of that. My recommendation in Pathway is to always get the initial history, like when you talk to the parents about why they're bringing their child in front of the patient. So that way the patient knows exactly what's being said about them. Then of course I do the typical getting the patient alone to hear their side. Just like in my 6 steps, I want to be on their side and hear what they have to say. I always ask a lot of futuristic questions to get a better picture. And by that, I mean, well, what do you want to do when you grow up if they're in high school? Or I even ask futuristic questions of small children, like, well, what about next year? Which parent do you want to live with? Or who do you want to be for Halloween? Or what do you want for Christmas next year? Sometimes if you can find out a little bit about the kid's understanding of the future, you can make a better assessment of what's going on psychiatrically with this patient. And finally, when we make a decision about the patient's care, I always do it in front of the patient and the parent. So everybody's involved in this decision. Now, this doesn't mean that I let the kid decide, but it does mean that it's done in front of the patient, so that way they don't feel like something is being hidden from them, right? So ultimately, the parent gets to decide if the patient goes into psychiatric care. Now, there are some exceptions to the rules, and you see this big orange box where the kids get to decide if there's issues about pregnancy, pregnancy prevention, or abortion. Well, that doesn't really apply to psych patients, right? And STD treatment and testing, they get to decide about that too. Again, doesn't apply to psych. life-threatening care. So if a kid was in a car accident, they get to decide if they want a blood transfusion, or the doctor gets to decide that. If the pediatric patient is for some reason or another married or in the military, and that usually has to be a parental consent situation, those two kids get to decide about their own psychiatric care. But otherwise, the parent has to decide always. Okay, it's always the parent. Now, another big thing that is very different for pediatric patients is that parents must stay the entire time with the kids. So that means that if the kid is waiting 4 days, they can't just leave, right? They have to be there with them the whole time. And then lastly, if you discharge a patient and you determine that they're not a harm or they're no longer at risk, or if you're holding somebody for a very long time, like let's say they're there for more than 4 or 5 days, you need to know a couple of psychiatric meds that you get used to giving, that you're comfortable with giving. Now I've listed these 4 on the side here, and these are my 4 psychiatric meds that I give a lot, that I get really comfortable with giving. So that means that I know which meds I can prescribe, which meds I can give to them while they're waiting, and what the side effects of the medicines are. Now, almost all psych meds, they say, usually takes anywhere between 4 to 6 weeks to have full effect. Especially true for the SSRIs, and these are the 2 SSRI medications. So that means that in the SSRI cases, the patients have to take meds for almost 30 days before they even notice a difference. Some patients, that's just too long, right? Especially those who almost committed suicide recently or something like that. So in that case, I have Wellbutrin and I have Zydus. That are my 2 medications that I'm very familiar with. So Wellbutrin usually will notice within 1 to 2 weeks. They notice things like better sleep, more energy, and better appetite within 1 to 2 weeks. So they're going to notice some changes within 1 to 2 weeks. But you're also going to have an increased risk of seizures on Wellbutrin. So that means that if this person is a well-known alcoholic, right, I don't give Wellbutrin to patients who drink alcohol because they can come back with seizures. So Wellbutrin will help a lot of patients if they just have some depression, and it helps within about 1 to 2 weeks. I always tell them about the increased risk of seizures. It can make tobacco taste very poor, so a lot of people get Wellbutrin to quit smoking. And Wellbutrin is usually dosed in an XR or SR form. It might be XL actually. Celexa and Prozac are 2 of the SSRIs that have the fewest side effects. But remember, it takes 30 days to notice a difference with these medications. And remember, I always tell the patients that I only prescribe 30 days because they should be seen by a psychiatrist or at least a family medicine doctor to get refills on these prescriptions. I also want them to know that they can have some side effects, and not every psych medicine works for every single patient or every single problem. Remember that no pill will magically make you feel happier. We don't have a happiness pill, but we can make you go from depressed to feeling a little bit more normal. Now, Zydus or olanzapine is an antipsychotic medicine, and I usually tell the patients it's a mood stabilizer. Olanzapine has been around a long time, but the brand name Zydus hasn't been. I like this medicine because it comes as an ODT tablet that dissolves on your tongue, which is pretty awesome. If you're uncomfortable with Zydus, a lot of people use risperidone instead. because that's a well-known mood stabilizer as well. These are the 4 or 5 medications that I'm usually pretty comfortable with prescribing or giving while I'm holding a patient in the hospital. And you should find at least a few to give that you're comfortable with giving in the hospital or as a prescription home. Otherwise, if you have any other psych questions, don't forget to check out your own state laws. Don't forget to leave us a comment at the end of this lecture. Please don't worry about my terrible spelling, and consider checking out our podcast at medmechanics.com. Thank you.